Thank you for that introduction, Jen. And yeah, I remember, I think you had just recently started here when I was on the faculty, when I was a resident and trying to help you navigate. I think we were still using Affinity at that time, that crazy system at County. But no, it's my honor to now be called a colleague with so many of you on this call who have been my mentors along the way, and Kevin Beckler, Matt Johnson, my first senior on medicine when I was an intern. So many good familiar faces here. So I'm going to talk to y'all today about postmenopausal osteoporosis, so Jen had kind of asked me to focus or to talk a little bit about beyond bisphosphonates. So I'm going to be talking about basically every medication we have out there that is currently approved for the treatment of osteoporosis and the reduction of fracture risk. And then at the end, I hope that if you have questions or cases that you want to talk about, we can just kind of have a discussion about situations where you might utilize these medications or some tricky situations. So with that, we'll kind of jump into it. These are my disclosures. So hopefully we're going to be able to meet all of these objectives today, and with the general idea being that we just want to be able to assess risk fracture and know how to decrease it. So we're going to start by defining the problem, looking at postmenopausal osteoporosis as a big picture, how to assess for risk and diagnose what we call osteoporosis using different fracture risk calculation tools, imaging, biomarkers, and then finally getting to kind of what we all are doing on a daily basis, treating and preventing osteoporosis using the therapeutic tools that are available to us. So in defining the problem, it's most important to realize that the goal of screening is to identify people that are at high risk of sustaining a fracture. And what type of fracture are we talking about here? We're really talking about these fractures that we call fragility fractures, low trauma fractures, because we do have validated treatments that can help reduce the risk of those types of fractures. We're not really talking about high impact fractures, right? We're not talking about fractures that occur with a lot of trauma, fractures from a car accident or a skiing accident or, rolling your ankle, something like that. These are things that, we look to, seat belts to avoid injuries from a car accident. We look to improving stability and helping with mobility to decrease the risk of other types of fractures. So we're talking about fractures that we hope our bones would be able to sustain at least a moderate amount of trauma and not break. So some people would define this as falling from a standing height or less. Fragility fractures, generally we define them as resulting from mechanical forces that would not ordinarily result in a fracture. It's obviously a very subjective definition, but one to keep in mind that not all fractures should be regarded as fragility fractures or fractures that are related to osteoporosis. You have to use your judgment to some extent. But we use this term osteoporosis to refer to people who are at risk for these types of fractures. And so people with osteoporosis, some of their characteristics might be low bone mass, microarchitectural disruption, increased skeletal fragility, all of this resulting in decreased bone strength and an increased risk of these types of fractures. Osteoporosis, as we define it, has no clinical manifestations until or unless there is a fracture. So a lot of patients will, without any symptoms, might incorrectly assume that there's no way that they could have osteoporosis and that the diagnosis must be incorrect. And conversely, many patients who have a variety of different pains in different areas, specifically the back and the hips, especially since since those are the areas that we measure with DEXAs, but also other areas like the knees or the feet, they assume that this must be a manifestation of osteoporosis, which is very unlikely unless they actually have a fracture in those areas. Much more likely that these symptoms that people would report would be due to osteoarthritis or some other kind of joint or soft tissue disorder. So making a diagnosis of osteoporosis is not really making a concrete diagnosis, a discrete yes you have it or no you don't kind of a thing. It's not like interpreting the results of a biopsy or interpreting the results of a test for an infectious disease. We are trying to risk stratify for fracture. We're not trying to make a yes or no diagnosis. So the way that we make this diagnosis, we sort of have to draw distinctions and draw lines in the sand, but these are arbitrary in a sense. So what are the sites that we would consider common for fragility fractures? These would be sites that are the spine, the hip, and to some extent the wrist. The wrist fractures can be tricky because most wrist fractures involve at least some amount of trauma. Most people don't develop spontaneous wrist fractures. So you kind of have to use your best judgment as to whether you think that a certain wrist fracture involves enough trauma that it should be considered a traumatic fracture. Someone who obviously is running at a very high speed, trips and falls on their outstretched wrist, that's probably not a fragility fracture. I think any of us, any human on earth could break their wrist doing that. Whereas someone who has a more minor fall, maybe that wrist fracture would be considered a fragility fracture. Less common, though possible sites of fragility fractures also include the humerus, specifically the proximal humerus, what we might call the shoulder, the ribs and the pelvis. Sites that we would generally not consider fragility fracture sites, since they usually do involve a fairly substantial amount of trauma, include the skull, the cervical spine, the hands, the feet, and the ankles. So fractures of the ankles almost always involve a rolling type motion, which usually puts a lot of torque on the ankle. And so we typically would not consider those fragility fractures. Fractures of the fingers and the toes, generally, we would also not consider those to be fragility fractures. So, how often is this occurring? So obviously, we've seen a lot of different statistics, some statistics that might get our attention. An estimate from 2000, so 23 years ago, at that time, there were 9 million osteoporotic fractures worldwide. So obviously the numbers have probably gone up, if anything, due to more, a higher population. In women specifically, the annual incidence of hip fractures range from maybe somewhere around or slightly less than 100 to about 600 per 100,000. And keep this number in mind, this per 100,000 marker, because that comes up when we talk about sort of the relative risks of some of our treatments. So keeping in mind that our risk of hip fracture maybe is on the order of several hundred or a few hundred per 100,000. Vertebral fracture rates are probably a little bit higher, getting to maybe around 1,000 or perhaps slightly more per 100,000. The highest rates of hip fractures tended to be, in this study at least, in Scandinavian countries. The highest rates of vertebral fractures were found in this study in South Korea and in the United States. Obviously, lots of fractures in all areas, though. Hip fractures affect up to 15% of all women and maybe as much as 5% of men by 80 years of age. And using the densitometric criteria that I think we're all familiar with, which is what was reported in this Haynes study, about 10 million adults over 50 and in the United States had what we would call osteoporosis, and 43 million had what we would call low bone mass, or what I think a lot of us refer to as osteopenia in 2010. So not an insignificant number. So when we talk about risk factors for osteoporosis and for osteoporotic fractures, the strongest risk factor, far and away more than any other risk factor, is a prior personal history of a fragility fracture. So someone who's already had one fragility fracture or osteoporotic fracture, whatever you want to call it, there is something about that person, about their bones, about their ability to avoid falls or inability to avoid falls, whatever characteristics about that person are present, they clearly are high enough risk that they already had one fracture. That is the biggest risk factor for them having another fracture in the future. And so given that, we can make a clinical diagnosis of osteoporosis in the presence of a fragility fracture without even bothering to measure their bone mineral density or calculating their fracture risk or making any other kind of assessment. Now, obviously, we are going to do those kinds of assessments in those patients to see, is there something reversible, and also as sort of a baseline to know where we stand. But those patients should be considered to have a clinical diagnosis of osteoporosis in the presence of any fragility fracture. A quick note on age and how it plays a role here. So we know that lower bone density is associated with a higher risk of fracture, but we also know that bone density tends to decrease with age, and we also know that age itself is associated with an increased risk of fracture, even controlling for bone density. So taking a look at this graph, you can see that all of these different lines represent different age groups of people, starting with a group of people 50 years of age at the bottom and 80 years of age at the top. You can see that as the T-score moves from right to left, or as the bone density gets lower, you can see that these lines spread out considerably, such that a 50-year-old with a T-score of -2.5 or -3, someone who we would, by densitometric criteria, as we'll go through, diagnose with osteoporosis, their risk of fracture is clearly much lower than the 80-year-old who has a T-score of -2.5 or -3. So bone density is one part of the puzzle. Age is another part of the puzzle, even controlling for the fact that bone density tends to go down with age. So what are the other major risk factors for osteoporosis development and, more importantly, for fracture? I think long-term glucocorticoid therapy is no surprise, although this clearly has a wide range, right? There's a lot of different ways to define long-term glucocorticoid therapy, and it's a dose-dependent relationship as well. So someone who's taking 5 milligrams of prednisone for, sort of maintenance therapy or long-term immunosuppression, this is very different from someone who needs to be on 20 milligrams of prednisone for months at a time to control their rheumatologic disease. Low body weight, low BMI, a parental history of hip fracture. So if either of the patient's parents, or certainly both parents, had a hip fracture, since we know that many, if not most, hip fractures do tend to meet our sort of criteria as fragility fractures, that would strongly suggest that there is some kind of genetic component of fragility fracture risk that has been potentially passed down to your patient. We know that cigarette smoking and excess alcohol intake are major risk factors for osteoporosis and osteoporotic fractures. Race, ethnicity are established risk factors as well, in that there are higher risk for osteoporosis development in people who identify as white, as opposed to people of Black, Hispanic, or Asian descent. And of course, hypogonadism, either menopause or other forms of hypogonadism in women, low testosterone in men. We know these are major risk factors for osteoporosis as well. Other maybe less well-established risk factors for low bone density and or fracture that have been shown in some, but maybe not all studies, include vitamin D deficiency, reduced functional mobility, recurrent falls, use of a walking aid, the presence of dementia, and poor health or frailty. A lot of these factors, probably just the fact that these patients are more likely to fall and sustain any kind of force that could cause a fracture. Other risk factors, again, with maybe less well established as major risk factors, but definitely seem to play at least somewhat of a role, include anticoagulants, especially heparin, and to a lesser extent, perhaps warfarin, the use of immunosuppressive medications beyond prednisone, especially cyclosporine, the use of medroxyprogesterone, the use of vitamin A and synthetic retinoids in high doses, loop diuretics, methotrexate, ifosfamide, imatinib, anti-seizure medications, most especially phenytoin, phenobarbital, primidone, and carbamazepine, but others as well. Proton pump inhibitors are a big one. So I think we're all familiar with the fact that proton pump inhibitors are very likely overused in many situations, and we know that proton pump inhibitors are for sure associated with lower bone density and may be associated with higher fracture risk as well. Even antidepressants, although probably a weaker relationship, thiazolidine-diones for sure, and antiretroviral therapy, specifically tenofovir, but maybe also protease inhibitors. What are some conditions, some other medical conditions that are associated with low bone density and or fracture? Hyperparathyroidism, rheumatoid arthritis, IBD, celiac disease, obviously a lot of these gastrointestinal issues that are associated with malabsorption, chronic uncontrolled hyperthyroidism, hopefully wouldn't stick around for long enough to cause major issues, but definitely something to screen for. Diabetes, both chronic liver and kidney disease, and sickle cell disease. In these patients, you're more likely to already have your underlying diagnosis, but these are patients that you might consider screening for low bone density earlier than in other patients. So how do we assess risk? So we already established that clinical diagnosis of osteoporosis can be made in the presence of a fragility fracture, even without having to measure bone density, calculate fracture risk, anything else like that. But for patients who don't have a prior fragility fracture, so in someone who you're trying to institute primary prevention of a fragility fracture, you can use a risk assessment tool. So there's multiple risk assessment tools out there. The one that is the most widely used is the FRAX, fracture risk assessment tool. This was developed in the UK. You can actually use this tool without a bone mineral density measurement. So you can still calculate an estimate of someone's fracture risk even before they get a DEXA done. But if you do have a DEXA, then you can plug in your bone mineral density measurement for probably a more precise or more accurate measurement. And it depends on country of residence and race. When they calculated these risks, they took that into account. As I said, there are other ones, other fracture risk assessment models available out there, but most haven't been validated in as diverse of a population as the FRAX tool has, and they're not in widespread use for some other reasons. Generally speaking, all of these tools seem to actually underestimate fracture risk. So don't necessarily take these as evidence of, oh, my patient's definitely going to be okay. Their fracture risk, didn't meet whatever threshold we might use. They do seem to be underestimates at best. Most of you have probably seen what the FRAX tool looks like online, but this is what it looks like. These are the things that they ask. And so I won't go through it in great detail. They have descriptions on the website as to, how do you decide for example, what counts as glucocorticoid use, what counts as secondary osteoporosis, et cetera. But so if you go through and you use this fracture risk assessment tool, what is considered an elevated fracture risk? That would be a 10-year risk of hip fracture that's 3% or more, a 10-year risk of any major osteoporosis related fracture at any site that's 20% or more. The sort of major organizations out there who issue guidelines on osteoporosis have all said that you can diagnose patients with a high risk of fracture, or in other words, what we're defining as osteoporosis based on the above, and they recommend using the FRAX tool for that. It should be noted that these cutoffs, these 20% and 3%, are again somewhat arbitrary in a sense. They're sort of country specific and are based on the availability of resources resources for treatment of osteoporosis. So it's obviously not saying that if your risk is above or below these thresholds that your patient is safe or your patient is doomed. It's just sort of we came up with these numbers to try and maximize the greatest benefit to the greatest number of people. A quick note on the term osteopenia. You'll still see it used frequently in bone density DEXA reports and whatnot. But the general tendency is to try and start using the term low bone mass or low bone density instead of osteopenia. One reason for this is that osteopenia started as a subjective term that was used to describe how bones looked on X-rays or CT scans, and then it became this objectively defined term in terms of bone density, and so it gets a little confusing when it's still used in both ways. And the other reason is that we also don't want to use it as a specific diagnosis, because people with low bone mass or low bone density are not necessarily at a high fracture risk. We've got to take many other things into account, and so using this term osteopenia as a diagnosis can be misleading into thinking that, oh well, you know, they're destined to become osteoporosis eventually. How can we use imaging to help us? So X-rays obviously can show us, like I said, to a subjective degree, what the bones look like, and can give us some idea about subjective osteopenia. You can start to see trabeculi get lost in bones that have a high amount of trabecular bone, such as in the spine. You might see the primary or the weight-bearing trabeculi might actually become thickened. That might be a compensatory mechanism, or might be due to microfractures that keep getting repeatedly healed. And so, like I said, you'll see this mostly in the vertebral bodies. You can see here that the non-weight bearing horizontal trabeculi, especially in this lumbar body right here, are kind of hard to see, whereas the vertical trabeculi actually seem to be even more prominent than usual. The DEXA is what most of us are familiar with now. Quantitative measurements of bone mineral content have been around for 50 or 60 years, but over the years they've advanced to the point where we have them now, where we use the DEXA, the dual energy X-ray absorptiometry. And so the dual energy refers to the fact that we send in X-rays at two different energies, one to account for the soft tissues that are in the area, skin, muscle, ligaments, and one to help us then go through the bone and give us an estimate of bone content. So what's the difference between the T-scores and the Z-scores? If you just remember simply that T-scores are used for postmenopausal women and men over the age of 50, Z-scores are what you want to use for premenopausal women and men under the age of 50. Although since T-scores are comparing bone density to a young, healthy adult population, for your patients that are premenopausal women or men under the age of 50, their Z-scores and their T-scores are probably going to be very similar. But this is generally how you want to use these measurements. And I think we all kind of have negative 2.5 ingrained in our mind as the T-score of interest for our older patients. So in conclusion, in terms of risk assessment and diagnosis, for your postmenopausal women, which will say a woman who's gone through menopause at least at the age of 40 would at least be not considered pathologic or not premature. And then your quote unquote older men, or just your men who are over the age of 50, our candidates for osteoporosis treatment are going to be those with a clinical diagnosis of osteoporosis, very low bone density defined as a T-score that's negative 2.5 or lower at one of these validated sites, the lumbar spine using at least two vertebrae, the total hip, the femoral neck, or the 1/3 radius, and low bone density, which we might still use that term osteopenia, and an elevated fracture risk using a validated calculator, with most organizations recommending the FRAX tool. I'll talk quickly about biomarkers of bone metabolism. We have markers of bone formation and we have markers of bone resorption. From a clinical sense, probably the only ones that are useful would be the markers of bone resorption, the N-telopeptide and the C-telopeptide. They're only studied real indication for now is not really for deciding whether to start treatment, but more for monitoring the efficacy of treatment. And in the case of bisphosphonates and anti-resorptive therapy, deciding when to restart treatment, basically. So if there's only one or one set of biomarkers that you remember and think about maybe using at some point, it would be the telopeptides N and C telopeptide as markers of bone resorption. So they're not really used regularly, like I said, for definitely for starting therapy, since the relationship between bone turnover markers and fracture risk have not been validated, but probably just looking at their ability to help you decide when to restart therapy, and maybe for some patients to help you decide if a certain type of therapy, absorptive versus anabolic, may be appropriate. So I won't go through every word of these, but basically, how do we decide who needs to be screened? I think there's good agreement now that all women 65 years of age and older should be screened. What about women younger than 65? The current recommendations say that screening for osteoporosis to prevent osteoporotic fractures in postmenopausal women younger than 65 who are at increased risk of osteoporosis should be done. And so how do they define an increased risk of osteoporosis? They say, well, one approach would be if you did bone density measurement testing in postmenopausal women younger than 65 who have a 10-year frax risk of major osteoporotic fracture without using DEXA, since you're deciding whether to do a DEXA or not. So you're not inputting BMD into the tool, that if it's greater than that of the average 65-year-old white woman without major risk factors, which they say is about 8.4%, then maybe it's worth doing a DEXA on that patient to further refine their bone density. So probably you're not going to go through the hassle of calculating a frax for most of your patients, most of your women, your postmenopausal women who are under 65. You're probably either just going to decide to do it or not do it. But if you're on the fence and you really wanted some kind of objective way to decide whether to do a bone density test or not on a woman under 65, you could go through the frax tool. And if her 10-year risk is greater than 8.4%, maybe it's worth doing a DEXA on that patient. So all women over 65 should be screened. Many women under 65, especially those with any major risk factors, should be screened. Patients need to be made aware that screening should occur even in the absence of symptoms. So remember that symptoms are not a prominent part of osteoporosis. The only symptom of osteoporosis is a broken bone, and we're trying to prevent that from happening. So risk factors are imperfect and incomplete. The classification of prior fractures as fragility fractures subjective. DEXA measurements are not actually looking at bone density. They're actually looking at aerial bone density. They're two-dimensional, and so they're limited in their accuracy in that way. Improper positioning during a DEXA measurement can certainly cause inaccuracies in measurement. People who have small bones, so if their bones are skinnier, then their two-dimensional bone density will tend to be lower, as opposed to people who have larger, thicker bones. Their bone density will be artifactually higher. There's also lots of other reasons why bone density might appear higher on a DEXA than it should, especially people who have already had a vertebral compression fracture. Their bone density in their spine might look reassuringly or falsely reassuringly high. So keep all of these things in mind when you're looking at your bone density tests. And it's always a good idea, if you have access to the actual images from the bone density test, to take a look and make sure that there's not something glaringly obviously wrong with the bone density measurement. An overlying piece of metal, one vertebral body that looks a lot smaller than all the others, cement from vertebral augmentation that's been put into one of the lumbar vertebral bodies that makes the bone density much higher than it actually should be. So if possible, always try and look at your bone density measurements if you have access to that. So the rest of the talk will be talking about what tools do we have to deploy. I'll talk just very quickly on non-pharmacologic therapy. So adequate calcium and vitamin D is recommended universally. What is adequate? It seems like probably for a postmenopausal woman, 1,200 milligrams per day is adequate, with the recommendation to try and maximize the amount that the patient gets from dietary sources, but utilizing supplements when necessary. With vitamin D, targeting a serum vitamin D level between 30 to 50 nanograms per milliliter, which for most people usually requires 1,000 to 2,000 IUs of supplementation per day. You might have some patients out there who are able to maintain levels to that degree with no supplementation, although there's probably not many of them. You have some people who might need more than this if they have some kind of malabsorptive issue. Doses up to 4,000 units per day. Given to people with normal absorption, no issues with absorption, has not been associated with any adverse effects except perhaps with some asymptomatic hypercalciuria, no actual increased risk of kidney stones or anything like that. So probably telling your, my routine is usually to tell patients to take 2,000 units per day. I've never seen a patient develop, vitamin D toxicity from that dose, and that seems to be an adequate dose for the vast majority of people, but slightly lower, slightly higher doses are generally adequate for most people as well. Patients ask me all the time about other vitamins, other supplements, magnesium, vitamin A, vitamin K, strontium, boron, you name it. Generally speaking, I just tell patients I don't really think there's consistent or robust evidence for benefit with really any of these things, but if you want to take them, I don't really have a problem with any of them, with the exception of we know excessive chronic vitamin A intake is associated with toxicity, including that to the bones. We want patients to minimize or avoid smoking, alcohol, caffeine consumption, cola drinks, so Coke, Diet Coke, diet soft drinks as well. These drinks, these soft drinks all contain phosphoric acid, which also can have detrimental effects on the bones. Carbonated water, just plain old carbonated water seems to be fine. No major issues with that. Physical activity and exercise, we're all taught that weight-bearing exercise, resistance training is good, balance training is good. All of these things are true, and patients should be encouraged to engage in a wide variety of different activities, but the frequency and the consistency of the activity is likely more important than the actual type of activity. Okay, so talking quickly about bisphosphonates. I know I'm supposed to be talking beyond bisphosphonates, but I can't ignore our first line treatment here. So bisphosphonates, they inhibit bone resorption via osteoclast inhibition and inhibition of osteoclast precursors. They decrease the rate of bone resorption, and this leads to an indirect increase in bone mineral density in many patients. We have alendronate, risedronate, zoledronic acid, which is an IV bisphosphonate, and ebandronate. All of these show improvements in vertebral fracture. So all of these are expressed in terms of relative risk ratios. So jumping to the vertebral fractures, we see 0.57, 0.61, 0.38, 0.67. So a 30 to 60% improvement in terms of relative risk reduction in terms of vertebral fractures. And all of them except ebandronate also reduce the risk of hip fractures. Technically, the risk reduction for ebandronate has not been established for non-vertebral and hip fractures, which is why it has maybe become a slightly less preferred option. But alendronate, risedronate, zoledronic acid, all well established in their ability to decrease vertebral, non-vertebral, including hip fractures. What are the risks and the safety considerations here for oral bisphosphonates? Esophageal reflux and is probably the biggest complaint. There are cases of esophagitis and even esophageal ulcers in extreme cases, although for patients who don't have extreme esophageal dysmotility, this is probably not a huge consideration. For the IV bisphosphonates, namely zoledronic acid, about a third of patients develop some kind of acute phase reaction or flu-like symptoms. These are self-resolving and go away after 48 or 72 hours or so. The shared risks that we know for all bisphosphonates, oral and IV. I think we've all heard about atypical femur fractures, and these are really quite uncommon in patients who observe a proper drug holiday. So for your patients who are worried about atypical femur fractures, I would say that the risk can be kept quite low as long as you keep track of how long the patient has been on therapy for, and we'll talk more about that in a second. Osteonecrosis of the jaw, I would say, is a rare complication complication. We'll talk about how to minimize the risk of that as well. Renal impairment, ocular side effects, especially uveitis, anterior inflammation in the eye, and atrial fibrillation have all been reported. And it seems very plausible that there is a relationship between the bisphosphonates and development of these complications, although they still appear to be relatively rare. In 2020, there was a study looking at women 50 years of age and older in the Kaiser Southern California system who had been receiving bisphosphonates to look at rates of atypical femur fractures. So the rates that were reported by age group, you can see here, they reported them in terms of 10,000 person years. I multiplied them to show you the rate in terms of 100,000 person years, because remember at the beginning of the talk, we talked about the risk of osteoporotic fractures, of hip fractures is on the order of several hundred per 100,000. Of vertebral fractures is on the order of about 1,000 per 100,000. So when you look at the risk of atypical femur fractures, we're talking orders of magnitude less than the risks of atypical, or excuse me, of osteoporotic fractures. And obviously there is a huge consideration here as to the duration of treatment. And so in the paper, they said, quote, the risk of atypical femur fracture increased with longer duration of bisphosphonate use and rapidly decreased after bisphosphonate discontinuation. They noted that people of Asian descent had a higher risk than people of white descent. The absolute risk of atypical femur fracture remained very low as compared with reductions in the risk of hip or other fractures with bisphosphonate treatment. So it's not that the risk of atypical femur fractures is zero. It's that as long as you stick to recommended treatment duration, the risk stays pretty low, and that even in the worst of circumstances, the risk is still orders of magnitude lower than an osteoporotic fracture. In the talking about osteonecrosis of the jaw, in the osteoporosis patient population, the incidence is less than 1 to 10 per 100,000. So again, going back to those previous figures, we're talking even another order of magnitude lower in terms of the risk of osteonecrosis of the jaw compared to osteoporotic fractures. The American Association of Clinical Endocrinologists does recommend an oral examination be performed before starting with anti-resorptive agents. This is not to say that you need quote unquote dental clearance. This is just saying that, maybe having the patient go visit their dentist if they haven't been there for a long time to make sure that there's not any major invasive dental issues that need to be corrected first is a good idea, but not an absolute necessity. And for your patients who have been seeing the dentist regularly, going once or twice a year and have generally good dental health, I don't think you need to wait for them to go back and see their dentist again. You can probably just go ahead and start them on treatment as long as they've been keeping up with their recommendations. The American Dental Association does not currently recommend stopping bisphosphonates for dental procedures. If a tooth extraction or an implant is planned or ongoing, you might want to defer starting a potent anti-resorptive until after the area is healed. For the American Association of Oral and Maxillofacial Surgeons, they recommend a 2-month drug holiday only for those who have taken 4 years of bisphosphonates continuously, and only when they're undergoing an invasive dental procedure. So you don't need to stop bisphosphonates for any patient who's undergoing any kind of dental procedure. A lot of it depends on how long they've been taking it and what kind of procedure it is. Talking specifically about IV bisphosphonates and how long should we be giving them for. The Horizon extension trial in 2012 looked at patients who were given zoledronic acid infusions annually for 3 years and then were randomized either to another 3 years, so a total of 6, or 3 years of placebo. And what they found basically was that there were fewer fractures in the group who got the 6 years of zoledronic acid. There were fewer vertebral fractures in the group who got more treatment, whereas other types of fractures, hip fractures and non-vertebral fractures, were not significantly different. There were small differences in bone density and bone turnover markers in those who continued versus those who stopped treatment, suggesting that the residual effects after 3 years of zoledronic acid persist, and therefore for most patients, or for probably your average risk osteoporosis patient, you could discontinue therapy after 3 years, but you might think about continuing for an additional 3 years, so a total of maybe up to 6 years for your patients that are at particularly high risk. So patients who have had a prior fracture or patients with very low bone density. And it should be noted that in this study of patients who got, even the patients who got 6 consecutive years of zoledronic acid, there were 0 cases of atypical femur fracture and 1 case of osteonecrosis of the jaw, although the numbers of patients treated may not have been high enough to observe this based on what we know about the relative frequency. Contraindications for oral bisphosphonates, abnormalities of the esophagus, which could delay esophageal emptying, any sort of surgical anastomosis in the GI tract where the bisphosphonate pill could potentially get caught, and an inability to stand or sit upright for 30 to 60 minutes. Common to oral and IV, we probably should avoid giving them to patients with creatinine clearance less than 30 to 35 mils per minute, and patients who have hypocalcemia, as we know that anti-resorptive agents are going to predispose to that as well. Talking about denosumab next, this is a monoclonal antibody with affinity for the nuclear factor kappa ligand or rank ligand. I won't go through this whole picture, but basically it's just saying that denosumab is a monoclonal antibody meant to replicate the actions of this OPG or osteoprotegerin. This is a natural endogenous substance that blocks the maturation of osteoclasts. So denosumab definitely seems to decrease the risk of hip fractures, non-vertebral fractures, and vertebral fractures, at least as well as the bisphosphonates, perhaps even slightly better. And in the one extension trial of patients on denosumab, looking at patients who took denosumab for 3 years versus placebo, patients were allowed to enroll in an open label treatment for an additional 7 years. What did they see? They saw 1 atypical femoral fracture in each group, both the placebo group and the extension group. There were 7 cases of osteonecrosis of the jaw in the long-term treatment group, 6 cases in the crossover group, so pretty similar. The yearly incidence of new vertebral fractures were similar in the groups during the first 3 years. And then the bone density increased from the baseline 21% in the lumbar spine. And we do see these fairly dramatic increases in bone density in the lumbar spine in these patients treated with denosumab. Lower, but still impressive increases in bone density at the hip and the femoral neck. The important thing to remember about denosumab, it's a great drug, as we see, decreases fracture risk, improves bone density, but drug holidays should not be performed with denosumab, as rapid bone loss occurs and the risk of fracture increases significantly after the medication wears off. So if you are thinking about putting a patient on denosumab, keep in mind that that patient should be kept on treatment indefinitely, permanently, or if it's ever a consideration to take the patient off of denosumab, or if therapy is going to be delayed for whatever reason, another very potent anti-resorptive agent, usually a bisphosphonate, needs to be given to prevent this rebound bone loss and fracture risk increase. The longer risk or longer duration of treatment, which, as we said in the study we looked at, the Freedom trial, they went for 3 years and then went for up to another 7 years for 10 years, suggests that if you keep patients on treatment longer, that they're actually going to have a more prolonged rebound or more profound rebound effect after you stop the denosumab. So the bottom line here is denosumab, great medication, but if you're going to put patients on it, they need to be on it for the long haul. You've got to make sure that they're coming in to get their injections every 6 or 7 months consistently. Talking about PTH agonists or PTH and PTHRP analogs. Here, these medications are acting on PTH receptors in the bone to stimulate osteoblast function, also to a lesser extent increasing gastrointestinal absorption of calcium and increased renal tubular reabsorption of calcium. We see a lot more effect on the trabecular bone than we do in the cortical bone, similar to denosumab, like we saw, that had that really profound effect in the vertebral spine, but not so much in the hip. Teriparatide is the first 34 amino acids of the intact PTH molecule. It actually, in a lot of studies, has not shown a great effect in terms of reducing hip fracture risk, but did decrease non-vertebral fracture risk in general. that includes hip fractures as well as other fractures, and had a major impact in terms of reducing vertebral fracture risk. Same thing with abaloparatide, which is a recombinant PTH-RP analog. Again, very significant reduction in the risk of vertebral fractures, less so in terms of non-vertebral fractures, and some studies that probably just weren't adequately powered that did not technically show a reduction in the risk of hip fractures. The side effects that I think a lot of patients get scared about is that there's this warning that says that some of the rats that were treated with teriparatide back when the medication was first being studied over 20 years ago, that some of these rats started developing osteosarcoma. Their osteoblasts became so active that they developed bone tumors. There's a couple of reasons why this might not be applicable to humans. Even though the rats were treated for 2 years, and 2 years is the duration of treatment for humans, 2 years is about 80 to 90% of the normal lifespan of a fish or rat, whereas 2 years is obviously a much lower percentage of the normal lifespan of a human. 2 years is about 25 or 30 bone turnover cycles in a rat. Rat bones turn over very quickly, whereas 2 years is only about 1, 2, maybe 3 bone turnover cycles in a postmenopausal woman. Rats also have longitudinal bone growth that continues throughout most of their life. So rats are getting longer pretty much their entire life. Their bones never really stop growing, as opposed to humans. We know we reach our adult height and then we're usually not getting any taller. So our risk of osteosarcoma is lower since our osteoblasts are not quite as active. We now have over 15 years of surveillance data that shows that the rate of osteosarcoma in patients using these medications is similar to the background rate of osteosarcoma in the population. So this actually led to the black box warning of osteosarcoma being removed from the PTH and PTHRP analogs. It is still in the labeling of the medication, but you can reassure your patients that unless they are part rat, we don't need to worry about them developing osteosarcoma. I want to talk about the sclerostin inhibitor known as romosozumab, which is the newest player on the osteoporosis market. How does this work? It inhibits sclerostin, which is a regulatory factor in bone metabolism that inhibits the Wnt beta-catenin signaling pathway, which regulates bone growth. I won't go through this in full detail, but basically the general idea is it seems like sclerostin inhibits osteoblasts and seems to stimulate osteoclasts. So to some extent, sclerostin is both inhibiting bone formation and promoting bone absorption. So if you inhibit sclerostin, then you get the opposite of both of those things, which is obviously good. We want to promote bone formation. We want to inhibit bone resorption. We see a decreased risk of hip fractures, non-vertebral fractures, and vertebral fractures on the order of 60 to 80% in terms of relative risk reduction. In one of the biggest studies comparing romosozumab versus alendronate, oral alendronate, patients were given romosozumab injections for a month, followed by 12 months of open label alendronate, or given alendronate the entire time. They saw a 48% risk reduction in terms of new vertebral fractures, awesome. 27% risk reduction in terms of clinical fractures, awesome. 19% risk reduction of non-vertebral fractures, great. But where did the black box warning about romosozumab and cardiovascular disease come from? It is this study right here. They saw that in terms of cardiac ischemic events, there were 16 patients, or about 0.8% in the romosozumab group, and 6 patients, or 0.3% in the alendronate group, which showed then that there was a 95% confidence interval that suggested a statistically significantly increased risk of cardiac ischemic events in patients who were on romosozumab as opposed to patients who never received romosozumab. It's unclear exactly why this was seen in this study. Hasn't been replicated in really any other large trials. And it's also postulated that alendronate and other bisphosphonates might actually have a protective effect in terms of reducing the risk of cardiac disease. So maybe it's not that romosozumab causes cardiac disease. Maybe it's just that the bisphosphonate group was deriving some sort of protection from the administration of the bisphosphonate for an extra 12 months. So this remains a black box warning for romosozumab, and your patients will definitely ask you about it. So generally speaking, it's hard to know, how to take this this finding. But what I do in my practice is, if I have a patient that I'm concerned is high risk for cardiovascular disease, so either they've already had a cardiovascular event, or they have long-standing diabetes, hypertension, severe dyslipidemia, or a very strong family history of cardiovascular disease, or they are actively smoking. Maybe those are patients where you don't want to use romosozumab. You don't have any of those risk factors, and for the right patient who's at very high risk of osteoporotic fracture, maybe that's someone that you'd feel comfortable deploying this medication in. So I just have the US box warning here: may increase the risk of MI, stroke, cardiovascular death, should not be initiated in patients who have had an MI or stroke within the preceding year, and consider benefits versus risks. I'll talk briefly on hormone replacement therapy and SERMs. HRT, no doubt about it, decreases the risk of fractures, hip fractures, vertebral fractures, and non-vertebral fractures. But I think generally the thinking now is that if you have a patient who's interested in HRT for other reasons, and the bone help is just sort of an added bonus, we'll take it. But if you are starting the patient on hormone replacement therapy specifically to reduce their risk of fracture, we have other agents that can act in a similar way in terms of fracture risk reduction, and don't come with the increased risk of breast cancer, which is not huge, but maybe substantial, or maybe a major factor for many patients. SERMs, the only SERM out there that is approved for the treatment of osteoporosis specifically is raloxifene, although we also know that tamoxifen also decreases fracture risk. Raloxifene really only appears to have efficacy in terms of reducing the risk of vertebral fractures, not hip or non-vertebral fractures. There's another SERM out there, bazodoxifene, which is only available in the US as a combination pill with Premarin. This medication is known as Duavie, and it's only approved for the prevention, not the treatment of osteoporosis. I don't use Duavie really very often at all. I do have some patients that are using raloxifene if they choose to not use other agents. So broadly speaking, these are all the medications we talked about. We can classify medications as anti-resorptives or anabolics, with the note that romosozumab also probably has some anti-resorptive properties as well. So what are our guidelines in terms of how to use these? So the general idea is that a lot of people now are saying, well, we have our patients with osteoporosis, which is our group of people who have high risk of fracture. And so maybe now we should also be splitting people up into high risk of fracture versus very high risk of fracture. And so these are some proposed criteria to diagnose someone as having a very high risk of fracture. So someone who's had a recent fracture, a recent fragility fracture, that is, fracture while they were on osteoporosis therapy, multiple fractures, fractures while on a drug known to be associated with skeletal harm, very low T-scores. Some people say less than 3.0, some people say less than 3.5, high risk for falls, a very high risk of fracture based on the FRAX tool, maybe taking those 20 and 3 numbers and increasing them by 50%, 30 and 4.5, and so they say maybe consider patients that are not at very high fracture risk, as defined above, to just be high risk, but not very high risk. And so, sorry, this is kind of hard to read, but basically the reason they bother defining people that way is to say that maybe those patients who are at very high risk, you should consider using some of those very potent parenteral therapies first. So abaloparatide, denosumab, romosozumab, teriparatide, or zoledronic acid IV infusion, as opposed to your other patients who are high risk but not very high risk. You could consider starting with an oral bisphosphonate, or maybe even raloxifene in some of those patients. This algorithm from the Endocrine Society, they basically say that for any of your high or very high risk patients, you could consider starting with almost any of these agents as primary therapy, and then probably moving on to the parenteral therapy only if the patient becomes higher risk or develops a fracture, and only moving on to these lower tier therapies, the SERMs and the hormone replacement therapy, if the patient is intolerant to or inappropriate for the sort of preferred therapies up here, the bisphosphonates, denosumab, the PTH, PTHRP analogs, and romosozumab. It should also be noted that SERMs are only for use in men, and hypogonadism should be treated in all men with osteoporosis unless they have a contraindication, such as prostate cancer. So basically, this is just saying that, we want to enact secondary prevention for your patients who have already had a fracture. You really want to make sure that you get them on therapy, because there was a study that showed that between 2002 and 2011, only slightly more than a quarter of patients were started on any form of therapy within 12 months after a fragility fracture, and that this number actually got worse over the course of the study. It started off at about 40%, and by the end of the study was down to about 20%. This might have been due to a theoretical concern that anti-resorptives may impair the healing of fractures, because this requires callus remodeling and coupled activity of osteoclasts and osteoblasts. I guess I'm kind of running short on time, so I'll basically just say that for patients that are naive to treatment, it seems like there's not any there's no significant difference in terms of delaying union or non-union of fractures, and so you can probably there are multiple studies showing that it's safe and effective to start these patients on any kind of therapy, including bisphosphonate therapy, early on in their course. So maybe even for your patients that you're seeing in the hospital, or certainly for your patients that you're seeing that you're taking care of in a rehab facility after a fracture, it might not be a bad idea to start that patient on a bisphosphonate before they leave you, to make sure that they get on some form of therapy. For patients already on therapy, obviously, if they had an atypical femur fracture, you should stop, and they're on a bisphosphonate, you should stop the bisphosphonate. If they have an atypical femur fracture while on the denosumab, you might want to stop the denosumab, but as crazy as it sounds, as counterintuitive as it is, you should probably start them on a bisphosphonate. Consider whether the patient should be due for a drug holiday or not. And if it's not an atypical femur fracture, it's just a regular fragility fracture, and they're not due for a drug holiday, it seems like there's not any harm to just continuing the treatment throughout the fracture healing process. Quick note on cost: bisphosphonates remain our first line because they are orders of magnitude cheaper than most of these other agents out there. But obviously, for your patients that are at high risk, paying $30,000 to $60,000 a year for a treatment course for a medication that could prevent further major fractures is definitely worth it. So I think I'll just kind of skip over these and go straight to my summary. We talked about the purpose of screening is to find individuals at high risk of suffering a fracture. That screening should occur by asking about prior fractures, assessing fracture risk using clinical factors, and performing a DEXA in the appropriate patient. Patients deemed to be at high risk and thus meeting criteria for pharmacotherapy should be counseled about their options, benefits, risks, and logistical aspects of therapy. Many patients may require intensification of therapy, drug holidays, which I didn't really talk about very much, but definitely are a requirement for bisphosphonates, or de-escalation of therapy based on changes or in clinical status over time. So sorry, I already went 1 minute over. So some people I know will have to run, but I'm happy to take any questions from anyone who is here.
Thanks, Braden. Lots of fantastic tips and take-home messages there. I know that Josh has a question. It's in the chat box. After stopping oral bisphosphonate for 1 year and obtaining a new DEXA, what percentage decrease in it is considered significant toward considering restarting therapy?
Right. So this comes down to basically how accurate is a DEXA? How precise is a DEXA, right? How good can you trust the measurement from a DEXA? And technically, in order to answer this question, you'd have to do what they call a precision analysis, which has to be done on each individual DEXA machine by each individual person who operates that DEXA machine to see, if you take a patient and you measure their bone density repeatedly, approximately how different or how much variation would you expect? This is not done for the most part. Obviously there's concerns about unnecessary radiation exposure to patients, et cetera, et cetera. But the bottom line is, I'd say if you're just kind of looking for a number to remember, that probably up to about 5% is probably like the margin of error on almost any DEXA machine. It varies by site, but if you just kind of want to remember a number, that if you see a bone mineral density change of less than 5%, that's probably not a significant change. That's probably, within the sort of precision margin of error of the test. So generally speaking, yeah, when I do drug holidays, I'll usually take the patient off. I usually wait at least 2 years because it usually takes, at least 2 years to see one of those significant types of change. And if you're always doing bone density testing too frequently, and you're always getting, a 2 or a 3% change, then you might miss the 7 or 8% change. But yeah, I would say at least a 5% change. But if possible, if you can look at the actual images from the study, a lot of times they'll have on there the LSC, the least significant change. And that will suggest that they actually have done a precision analysis. And you can actually see for each individual facility, each individual machine, what absolute change you would expect would be considered significant and not just due to noise in the test.
Thanks, Braden. I'm going to, while we still have most of the audience, I'm going to quickly just say a couple of housekeeping things. Brandon asked me to remind everybody to text your CME code. I'm having technical difficulties. I don't know if anyone else is, but please let us know. Barbara's question about getting copies of the slides. We actually upload all of these talks onto our YouTube channel. So if you subscribe to our YouTube channel, you're in, you have copies, access to copies for all of these things. Are there any other clinical questions? I actually have a couple, but I want to open it to the audience first. Okay, well, let me fire away then, and anyone can jump in if other questions develop. We have, especially over at County, I feel like a ton of patients who have either advanced CKD or end-stage renal disease. So bisphosphonates are, I believe, contraindicated under CKD like 4.
Right. So yeah, the treatment of low bone density and fracture risk assessment in advanced CKD, which we'll say is like CKD stage 4 or worse, so a GFR 30 or worse, is really challenging. So there's a couple of things to keep in mind. Number one, as I put up there, chronic renal disease is an established risk factor for fracture. So we know that independent of bone density, people who have advanced kidney disease, CKD 4 or worse, have a higher risk of fracture. So that's something to keep in mind. Number two, we know that people with advanced kidney disease tend to have lower bone density than matched people without kidney disease, right? So it seems like just progressing through the stages of kidney failure tends to make your bone density worse. And that's probably at least part of the explanation as to the higher risk of fracture, but obviously there's other factors that don't get measured in a bone density test as well. But then the question is, does treating these patients with any medication, does it actually seem to decrease the risk of fracture, right? So we'll start with bisphosphonates. So you brought up, in the labeling, it says bisphosphonates should not be used in patients who have a creatinine clearance less than 30 or 35. That's mostly to say that that they could potentially cause like an interstitial nephritis. But there have been studies where they've looked at using lower doses, lower intensities of bisphosphonates in patients with advanced renal disease. And it seems like that's safe to do, that you can sort of renally dose these medications, right? But the question is, does it actually lead to decreased risk of fracture? And it seems like the answer is maybe in some patients, but definitely not in all. And the reason is because a lot of patients with advanced CKD will actually have what's called adynamic bone disease, or they'll have bone that's turning over at an even slower rate, right? So their problem isn't that they have tons and tons and tons of bone resorption. It's not that their osteoclasts are like really highly active. It's that their bone is like not really doing anything. And so putting those patients on an anti-resorptive agent like a bisphosphonate might actually be worse for them. It might actually make their bones even worse and more brittle, because you're basically now just freezing their bone in place. And now there was already very little osteoblast activity, and now there's no osteoclast activity. And that could potentially precipitate an even worse situation. So for that reason, even though, like, if you look at denosumab says, well, yeah, actually, since it's, there's no risk of any nephropathy or nephrotoxicity or anything like that, maybe we should put all of our patients with advanced kidney disease on denosumab, since we know it won't hurt their kidneys. But there's not actually consistent evidence that shows that it decreases fracture risk. And in some patients, it could actually even make the situation worse. So my general recommendation is, for most patients with kidney disease, getting a DEXA might actually not really be so helpful, and it might actually sort of be misleading if they haven't had a fracture, or that you don't think they're really, really high risk for a fracture. Generally speaking, we probably need better tools to assess this risk, but secondary prevention is kind of the name of the game when it comes to fracture risk reduction or fracture risk assessment in advanced kidney disease. What's most important is managing their secondary hyperparathyroidism. So making sure that you're not letting their PTH levels get too high, making sure that you're not suppressing their PTH levels too low, managing their hyperphosphatemia. So I'd say optimization of bone health in advanced kidney disease has less to do with medication or osteoporosis medication and DEXA screening, and more to do with looking at their phosphate and looking at their PTH levels.
Okay, great. And speaking of secondary prevention, what about, is there any concern? It just seems like physiologically, if somebody has a fracture and you start them on one of these therapies, does that impair fracture healing?
It seems like that should be the case, right? And I think our brain would tell us that, oh yeah, like you shouldn't put someone on an anti-resorptive agent right after a fracture, because you need the osteoclast to go in there and absorb away the damaged bone to build a bone callus. But when they've actually looked at this and studied this, now granted, it's not like there's big, huge randomized controlled trials out there about this, but when they have actually done a lot of retrospective analyses and even a couple of prospective analyses, when they've put patients on bisphosphonates, in some studies they waited 2 or 3 weeks. In some studies they just put patients on right away. There is no consistent effect that it caused delayed union, malunion of the fracture, anything like that. Maybe in some cases it seemed like the fracture took a little bit longer to heal, but in other studies it actually showed that the fracture healed faster. And so in that case, my general message is, I think I don't have a problem with anybody starting a bisphosphonate right after a fracture. I think as long as the patient, it's not an atypical femur fracture, like I said, obviously that's a different story. But for your, patient that you're seeing in the hospital who's there with a hip fracture or here with a vertebral fracture, if you're concerned that they're not going to get started on the proper therapy and you want to make it your habit to start that patient on an oral bisphosphonate before they leave the hospital, I think there's ample evidence out there to justify doing that.
Great, thank you. Matt Johnson has a question.
Are orthopedic surgeons okay with that?
I think in the ones that I've worked with, they usually just like defer to whatever I say, and they're like, yeah, they're like in their head, they're kind of like, oh, well, yeah, they can cause those atypical femur fractures, but if I've said, hey, I think that this patient would benefit from going on a bisphosphonate right now. Generally speaking, I think there's ample evidence to show them if they did have a problem with it, but most of them are kind of like, yeah, whatever, as long as you think that's the best thing. Now, granted, most of the time, if possible, if I have a patient who had like a really bad fracture or they've had multiple fractures, those are the patients that I might try to put on anabolic therapy, right? So by the time they get to me, usually they're out of the hospital. And if I'm going to try and put them on anabolic therapy, then I'm not going to do the bisphosphonate anyway. But I've had plenty of patients who I've suggested, hey, let's put you on teriparatide. And they go, okay, what's the deal with that medication? Well, it's a daily subcutaneous injection that you've got to give for the next, 18 to 24 months. Patients go, nope, I'm not going to do that. What else you got? And so those patients, I'll put on a bisphosphonate, and I won't really hesitate about it. Because yeah, I think that I totally agree with what Jen said, which is, our sort of what we know about bones and fractures and anti-resorptives in our head. We're like, that shouldn't work. You should wait until the fracture's done. But the evidence would suggest otherwise.
Thank you. I have a couple more questions. Anyone, if you don't mind, Braden, if you don't have to.
Not at all. No.
And anyone else is still always welcome to chime in. Maybe this is a countyism too. Ergocalciferol. I almost never use this in my own practice. I kind of do your like 1,000 to 2,000 cholecalciferol a day. And from what I've read, there's no super compelling evidence for ergo, but please correct me if I'm wrong.
You're correct. So yeah, this is one of those things that I think we kind of step on ourselves a lot and get ourselves confused over sometimes. So yeah, ergocalciferol and cholecalciferol, vitamin D2, vitamin D3, both are inactivated vitamin D. So both of them, you're going to ingest them. They're both going to go to the liver and become 25 hydroxylated, and then eventually can be converted to activated vitamin D by the kidney later on. Both of them seem to be effective. Both of them really seem to work about the same. Probably a slight edge to cholecalciferol or vitamin D3 in terms of absorption, in terms of half-life and longevity and things like that. But ergocalciferol is good too. From a practical standpoint, and the reason that ergocalciferol is even still in the equation is because of those 50,000 unit, mega doses, right? So if you go to, most pharmacies, and if you tell your patient to order vitamin D off of, Amazon or Costco or Walmart or whatever, all of those supplements are vitamin D3. There's really very few supplements out there, over-the-counter supplements, that still contain ergocalciferol. They pretty much all converted over to D3 cholecalciferol at this point, right? The only type of ergocalciferol that has stuck around is this 50,000 unit megadose capsule. And they also make 50,000 unit doses of the cholecalciferol as well. They're just a little bit more expensive, and they might not be on formulary. And as definitely here at County, as you referred to earlier, the 50,000 unit cholecalciferol is not on the County formulary. And so if you prescribed that, the patient would have to pay for it out of their own pocket, whereas the ergocalciferol would probably be free. But then there's the question, well, is there any benefit to putting a patient on 50,000 once a week, as opposed to what if you gave them cholecalciferol 10,000 units per day, and you told them to take 10,000 units of cholecalciferol per day or 70,000 units per week? Is there any difference between those two things? I guess just the difference is that you're telling a patient to do something once a week versus every day, which some patients might like better and some patients might not like as much. So in my practice, the only time I'm prescribing the 50,000 unit or the only time I'm prescribing ergocalciferol at all is when I'm giving someone the 50,000 unit capsule. And that's really only when I have a patient who, they've probably had another doctor who prescribed it to them, and they go, oh yeah, I really prefer to have the once a week administration as opposed to the everyday administration. Otherwise, there's really no reason to prefer ergocalciferol to cholecalciferol. There's maybe some reason to prefer cholecalciferol D3 to ergocalciferol. But yeah, if you tell your patient to go and buy an over-the-counter vitamin D supplement, you can rest assured that 99% it's probably going to be D3.
Okay.
Which is good. It's what we want.
One more question for you.
Yeah, of course.
Men, for primary prevention, outside of chronic steroid use, outside of maybe hypogonadism, risky stuff like anti-epileptics, should we be screening any of them?
Great question. So, we have this monthly endocrine case conference on Wednesdays where our fellows present, a case that they saw recently and sort of do like a review of the literature about it. And actually just yesterday, one of our fellows presented on osteoporosis in men specifically. She brought up the current guidelines from one particular body, so the Endocrine Society guidelines, which say that all men over the age of 70 should be screened regardless of risk factors, and that men between 50 and 70 should be screened in the presence of risk factors. That is not a universally adopted recommendation. That is one society's recommendation. There are other societies and other bodies that recommend screening at a higher age. Some say screen after 75. Some say screen after 80. Some say don't screen men at all unless they have major risk factors, or if they've already had a fracture, do it to get your baseline DEXA reading. And it's a really good question, and one that doesn't have a universal answer at this time. And so I think obviously if a man has had a fragility fracture, and so now we're talking secondary prevention, that man needs a bone density test, not to diagnose him with osteoporosis, but as a baseline so that you can monitor bone density in response to treatment going forward. As you said, major risk factors. So, hypogonadism, chronic steroid use, seizure medication use, chronic alcoholism, smoking, chronic liver disease, probably justifiable to start screening those men in their 50s, right? All other men, it's kind of a question mark, right? And I think it kind of depends on the patient, right? If it's your patient where you struggle to get them to take any of your medical advice and struggle to get them to do anything, take their blood pressure medication or get a colonoscopy or whatever, then maybe getting a bone density test is not going to be a very fruitful exercise for you, because even if they do have osteoporosis, they're not going to take the medication that you recommend to them. Whereas if you have a patient who's very gung-ho and wants to do everything they can about their health, then maybe getting a DEXA in their 50s if they have risk factors, or when they're 70 if they don't have major risk factors is worthwhile. Dr. Turner mentioned, what about loss of height, say a couple of inches in men? Absolutely. Loss of height suggests either that they're losing height in their vertebral discs, or that they've lost height in their vertebral bodies. So men or women who report significant loss of height, getting a bone density test, I think, is always warranted, and maybe even getting lateral imaging of the spine is warranted as well, just getting plain film x-rays of the spine to screen for an occult vertebral fracture. So yeah, it's a tough question, the osteoporosis screening in men for primary prevention, one that has different recommendations from different people. My personal approach is I'd probably say that maybe sometime during their 70s, I might get a DEXA for many men. And then probably if I see a man in his 80s who hasn't had a DEXA yet, I would probably go ahead and get one.
Okay, great. Thank you very much for a great talk that is certainly going to make me think a little harder about some of my own patients and how I want to manage them.
Absolutely. Yeah. I mean, it's just another thing to think about, and on top of the dozens of other things that we've got to think about for every patient. So, luckily this is something that it's a long-term game. And so as long as we, address it at some point, hopefully we can reduce the risk. We're probably unfortunately never going to eliminate fragility fractures completely, but just trying to minimize the risk is the best we can do.
Great. Thanks, Braden. Take
Thank
care,
you.
everybody. Thanks for sticking with us. Have a good month.